Hello again and welcome to part 2 of our video series on vascular ring anatomy. In this video, we will be using the double aortic arch as an example to discuss the clinical presentation, workup, and treatment of vascular rings more broadly. Vascular rings can present very differently depending on the degree and position of the structures compressed. Frequently, vascular rings are divided into two categories, complete and incomplete vascular rings. This logically refers to whether the vessels form a complete ring around the compressed structures or an incomplete one. In general, complete vascular rings tend to cause more severe symptoms, often before 6 months of age. The double aortic arch tends to be the most severe, usually presenting before 3 months of age. Nevertheless, as you will see in upcoming videos, incomplete rings such as the LPA sling can also present in infancy with severe symptoms. So next, let's review the typical history and presenting symptoms in patients with vascular rings. Commonly, patients will present with in-story stridor, which is actually the most frequent manifestation of vascular rings in infancy. They can also present with biphasic wheezing. They can present with dysphagia or feeding problems of varying severity. They can also present with reflex apnea due to occlusion of the tracheal lumen, usually during feeding. And finally, they can present with a history of pneumonias, which are more commonly found on the right side. The physical exam will often be completely normal unless the patient has rhonchi secondary to pneumonia, or if the patient has associated congenital heart disease, which is seen in about 25% of vascular ring cases overall. So how do you work up a patient who presents with symptoms concerning for a vascular ring? Well, you start with a chest x-ray to assess for tracheal compression. Anterior compression on a lateral chest x-ray is highly suggestive of a vascular ring, as 95% of patients with vascular rings or slings have visible abnormalities on a chest x-ray. You may also see hyperinflation or atelectasis in the setting of a pulmonary sling. The next study is still under debate, but many clinicians are now opting for a chest CT or MRI along with an echo to rule out associated congenital heart disease. Other clinicians will still start with a barium esophagram. Next, we will discuss the double arch in detail. This lesion originates from failure of regression of both the right and left fourth branchial arches. Consequently, only the right ductus regresses, leading to a complete vascular ring surrounding the tracheobronchial tree and the esophagus. Typically, the right arch is dominant in about 75% of cases, meaning that it's larger and is more superior. Most commonly, the double aortic arch is an isolated anomaly without associated congenital heart defects, although it has been associated with transition of the great arteries, VSDs, truncus arteriosus, tetralogy of Fallot, and coarctation of the aorta. These patients generally present with respiratory difficulties in early infancy, often in the first few weeks of life, in addition to swallowing dysfunction. As I said before, this is actually the most common symptomatic vascular ring in infancy. Infants will often hyperextend their necks to reduce tracheal compression. Now let's review the patient data set. As you can see here, we have again maintained the same color scheme with the ascending aorta and the descending aorta in red. However, this time we've actually marked the right and left arches in the color white due to the persistence of both arches. The common carotids are again shown here in orange, and the subclavian arteries are shown in pink. You can see that the right arch is larger and more superior, which as we mentioned before, is the most common presentation to see in a double aortic arch. Viewing the data set from a superior perspective, you can appreciate that the persistence of the right arch forms a complete ring around the trachea and esophagus. The trachea and the esophagus are compressed with proximal dilation of the esophagus visible here. Treatment of this lesion involves surgical division of the smaller arch through an ipsilateral thoracotomy. If both arches are completely patent, as shown here, the narrowest segment of the smaller arch is ligated and divided, which most commonly ends up being the segment between the subclavian and the descending aorta. If there's an atretic segment of one of the arches, that segment is divided. So with that, we will pause our discussion here. In our next video, we'll be discussing a complete vascular ring, the right aortic arch with an aberrant left subclavian artery. Thanks for watching.